Dear Professor Vester, as we are facing the horizon of your 5th year of AMN Presidency, please share with us some of your past and future thoughts regarding the evolution of the Academy.
Yes, evolution is the right word. Science and medical knowledge is always a snapshot. It can never capture the full truth. It's an ongoing process, and this applies also to a scientific society as the AMN. It has to advance in order to stay a living and prospering entity. So, I'm excited that important developments at the AMN have come into life in the recent years, also during my presidency here. Great educational endeavors, production of advanced international treatment guidelines, cutting-edge research implementing the multidimensional approach, which was so necessary to promote this, and so on. It's a living society, and I'm excited to be a part of this. And at the end, this is also reflected by the change in the dynamic way the Academy outreaches the people, which, last but not least, is also expressed in the rebranding of the AMN.
When looking at the development of translational and clinical research concepts in the last decade, one might see dramatic changes. How would you outline the new multidimensional methodology applied to classic evidence-based medicine concepts?
Good question. In fact, there are dramatic changes. If we have a look at TBI research, the Glasgow Outcome Scale, for instance, a single functional assessment scale was dominating clinical research for decades, with only few steps between death and full recovery. So with a very low resolution of outcome, mostly even further broken down to a simple binary scale of just favorable or unfavorable outcome, such as simple black and white thinking, which dominated research also in other fields, like in stroke, with the modified ranking scale. Of course, that can never capture the full breadth of outcome in such complex domains as recovery after traumatic brain injury. And such simplified approaches, which dominated research so long, are just not able to identify important deficits of the patient. That's where we have to focus on the patient as a human being. As opposed, the multidimensional approach is addressing the full breadth of consequences after neurotrauma, such physical functioning, but also cognitive functioning, mental health, social integration, social communication, quality of life. That's also important, that I feel after the trauma come back to what I was before. Not just that I can move my hand or something like that. So also including neuropsychiatric, cognitive, emotional, psychosocial aspects, very important. And this way, I would say it's a holistic approach across all pertinent health states and life domains of a patient. It's patient-centered, considering multiple facets of their health and well-being. And fortunately, cutting-edge statistical procedures, which are necessary, based on correlation-sensitive full-scale analysis, are meanwhile established for this approach. And the International Biometric Society, for instance, initiated workshops on how to apply these high-tech new statistical procedures. And the AMN, it was an integrative part of this important development, disseminating the necessary knowledge to the people, to the community, and to consistently promote the importance of the switch from the old single outcome paradigm, black and white, to future-oriented multiple outcome approaches which capture the full picture of the patient as a human being.
All right. In the field of TBI, how do you see the contribution of non-interventional studies and real-world evidence to the general concept of evidence-based medicine?
Well, let's say basically real-world evidence is an important contributor to the knowledge of how best to treat patients. Why? Because at the end, it's the real world where the benefit has to happen with the real patient. And unfortunately, non-interventional trials, when it comes to international guideline production, they enter the stage through the door of low evidence, whatever they are. The first label is low evidence. Randomized controlled clinical trials enter the stage with high evidence. But unfortunately, those non-interventional trials, if they have dropouts, if they have some bias problems, they are further downgraded to very low evidence or no evidence. And that's a tragedy, because if observational trials are downgraded that way, years of research and researches are lost completely. You have nothing at the end in your hand. Again and again, that happened in the last 10, 20, 30, 40 years. So fortunately, new effective pathways are now available and have to be established to avoid this tragedy. And one of the key milestones for to avoid this was the GRACE guideline. That's the guideline for high quality effectiveness research in observational trials or non-interventional trials, with a very strict comprehensive ensemble of rules and to-dos, now paving the way for non-interventional trials to be upgraded to higher levels of evidence. And such trials following these new high-quality principles can now become serious co-players in the world of evidence-based medicine. So I'm not the poor kid anymore. You have to go to the low evidence. If you come with this high-quality approach during the whole conduct of the trial, then you can contribute in terms of evidence, and the years of research are not lost. So that's an exciting development.
To your knowledge, are there specific medical journals keen to publish real-world evidence studies, and is there a particular trend in this respect?
I would say if we want to play on the international level of evidence-based medicine, we should treat such high-quality non-interventional trials equal and try to publish in the same journals as randomized trials. You know why? Because otherwise we have the danger that we are put into a niche and that these trials are separated. This is the opposite of what we want. We want to get them from the cellar on the table because they are now following these high-quality principles. And so they are comparable to randomized trials, and they can speak in terms of evidence-based medicine. So I would not separate that. I would not go to specialized journals just for this kind of trials.
All right, and for my last question, I wanted to ask if you could please describe some advanced projects that illustrate the development of the AMN within the new frame of thinking.
Yeah, I would say, let's start with the Captain series of trials. That was the biggest breakthrough, and I would say the most important development for the future. That was the first multidimensional approach in TBI research based on full scales, applying all these new cutting-edge methodologies. And in fact, the Captain trials, which are completed now, are the worldwide first randomized controlled clinical trials in TBI based on a multidimensional approach. And it was a great endeavor. If you do something new, you will see that there are a lot of resistance. People don't want to leave what they did since 20 and 30 and 40 years. But it was successful at the end, and the methodology, because it was so new, was published in advance, very important, in the Journal of Neurotrauma. And after a challenging road of more than 6 years, I would say, the Captain trials did not only demonstrate the feasibility of such an approach, which is very important, but much more, leading to high evidence in terms of consistent, statistically significant results. So we have something in the hand, we have evidence in the hand, more evidence, more test power than we would have with arbitrary selection of single outcome scales. With this multidimensional approach, it's like an airplane which you are flying with more than one motor only. It's much more stable and has more power, and so that was a very successful but very challenging road to establish that. And after the first 2 successful Captain trials in the series, the third one is now underway, the C-return studies. It's following this approach, applying high-quality measures, not only in the planning, but also in the conduct of this trial with high quality and risk-based management of the data and the whole conduct. So then to mention the CREST study, that's, let's say, the real world translation of the Captain series, which was randomized, controlled, double-blind, and. The CREST is real world, but with the same multidimensional approach, because it's also important to show that there we can work with this approach and that we have power, test power, and that we can create evidence for high-quality comparative effectiveness as expressed by these new GRACE guidelines. And last but not least, I should mention the performance of formal meta-analysis, combining the existing evidence of these multidimensional approaches by state-of-the-art methodology based on principles like Cochrane, Consort, PRISMA guidelines, and so on. That also was successful. And I should mention the present project, which is somehow related to CREST, to real world approach, collecting the necessary data items within the framework of a registry, and thus allowing inclusion of the greater range of population and of a greater range of real-world settings. So this is ongoing in the moment, and all these are cutting-edge approaches, opening new pathways to the future, and that's what the AMN is here, at the end, for the benefit of future patients.
All right. Thank you so much for the interview.
You're welcome. Thank you. Thank you very much for the questions.